Hello, everyone. I'm Rashad Collins, the Chief Executive Officer here at Neighbor Care Health.
Faisal, Director of Public Health for Seattle and King County.
Yeah, happy to be here with everyone today to further the community chats for Neighbor Care Health as part of our 2024 Spring Give campaign. So I thought I'd start out by talking a little bit about Neighbor Care Health and what we do, and then I'll turn it over to Dr. Collins to do the same. So Neighbor Care Health, we provide comprehensive healthcare services to underserved communities. We've been in existence for over 50 years, serving the majority of Seattle, King County, and few of our very important service lines are inclusive of medical, dental, behavioral health services. We provide care in 17 school-based health centers. We also have a midwifery program. We're the largest healthcare for the homeless provider for community health centers in the city of Seattle. And we are also the largest provider of adult dental services. And we continue to work with and partner with our communities to meet the needs of underserved communities that we know have been marginalized for so long in Seattle, but also in our greater society. And it's through strategic and intentional partnerships with organizations such as Public Health Seattle King County that we're able to do that in a very intentional way with an eye towards how to make significant improvements to improve the health outcomes of our communities and everyone who resides within them. So with that, I'll turn it over to Con.
Thank you, Rashad. And I just realized the camera does add about 10 pounds on each side. So he's better looking than I am, which is why he looks so smart and suave on the screen. But, you know, it's an honor to be here. Community health centers, in my opinion, are a true community asset wherever they are. It is one of the greatest achievements of Congress and the federal government over many, many decades. The fact that they established community health centers, the fact that they continue to support in a bipartisan, bicameral manner, community health centers and their mission. Without them, so many people, hundreds of thousands of men, women, and children across the country would be left without critical care. In the world of public health, Rashad and his colleagues are what I would consider an extension of the public health workforce. They are the very seams on the safety net that we talk about so often. So to that extent, our missions in government public health and community health centers could not be more aligned, even if we tried.
Yeah, no, I agree with that wholeheartedly. You know, and especially when we think about, you know, during the pandemic, it really shined an even brighter light on the community connection and the importance of that extension of public health.
Absolutely.
You know, our work and our mission, it relies on us to step outside of just what is the typical services that we provide within an exam room. It's really looking at community and seeing what some of those social drivers and social determinants are. What are some of the opportunities we have to provide them directly, but more importantly, what are some of the opportunities we have to engage communities in partnerships, because we can't be all things to all people. And it's extremely important that we're able to provide not only the referral linkages, but also the handoffs in a way that we're not losing the importance of what we're aiming to accomplish at the point of that transition. You know, we know a lot of times that vulnerability occurs at the point of handoff. And, you know, through our contractual agreements and arrangements, as well as the partnerships that we have continued to forge over time, it allows us to do that in a way that is very intentional and beneficial. A couple of things that we wanted to talk to you all about. And so as we talk about, you know, the collaboration, our collaborative effort, and specifically talking about health equity, right? What are some of the ways that you see from a health equity perspective that, you know, our organization separately and collaboratively align?
Oh, goodness. You know, that is a great question. It's also one that is critical to keep answering over and over again. As I mentioned earlier, our missions and visions and core values align perfectly. But what does that actually mean? So let me just talk about the world of public health for a second, and then I'll establish the bridge with community health centers. Only 20% of the determinants of health, or what goes into determining health outcomes, depends on the clinical care you receive, the quantity, the access, etc. Research has proven that 80% of what goes into determining good health belongs to a totally different sector: transportation, school systems, housing conditions, wages, generational poverty, and so on and so forth. The entire bucket of the social determinants of health that Rashad just referenced. And that's where our two worlds really intersect most of all. Community health centers are known for the high quality primary care services they provide, no doubt about it. They're measured on it, they're accountable for it, they report out publicly for it, and they get rewarded for improvements in quality of care. Public health also has a clinical presence. We have about 11 public health centers located throughout King County, which are funded by the taxpayers of King County. And those provide another layer of critical support to all the people who may not necessarily have access to community health centers, or who are in a phase of their life, they they're refugees, they're immigrants, they're asylum seekers, or they just happen to live in close proximity to a public health center as opposed to a community health center. So the two systems really do work tandemly. And we have joint sites located with so many community health centers across the region, as well as co-operated school-based health centers across the region. So the two worlds are totally entwined. On the subject of health equity that Rashad mentioned, if any of you have seen that circular diagram, it's beautiful, which captures the 12 essential functions of what we do in public health: assess, evaluate, research, provide services to people. The center of that circle is equity. Nothing happens without applying the health equity lens to our planning process, to our implementation process, or our evaluation and report out process. We take great pride in the fact that we're accountable in a bidirectional manner, not just to the taxpayers, most importantly, but also to the decision makers elected by the taxpayers. So we're held accountable 3 ways from Sunday, so to speak. But, you know, Rashad hit upon another gem, which I do want to work in here, and I know you agree with me. Somebody asked me this question at a conference last year, you know, what do you think about the American healthcare system? And to rephrase Mahatma Gandhi, I think it'd be a great idea. And I say that because what we have in the United States today is not a healthcare system. It's a clinical care system. If you can afford it, you'll get the best clinical care available to you in the world, bar none. We have the latest technology, all the right equipment, the best trained physicians, clinicians in the world. And yet, 1 out of 3 Americans is only 1 major medical bill away from bankruptcy. So who steps in to bridge the gap? Community health centers. Without them, our population would suffer to an extent that I can't even begin to describe, much less the fact that they provide an improvement in health status indicators decade on decade that no other system can. So whenever the question of supporting or funding community health centers comes up, it's a no-brainer. Politicians and decision makers across party lines may not agree on anything else in the world. They do agree on this for good reason.
Yeah, I appreciate that. And I think, you know, that speaks to multiple touch points that you referenced. You know, first and foremost, in talking about equity and really leaning into that head on, you know, it certainly makes it extremely important for us to ensure that the services we're providing, how we're providing them, and where we're providing them are intentional in serving multiple populations, right? So we know as we are truly specific about the difference between equity and equality, in that, everyone in our service, everyone has access to community health center services, right? Regardless of ability to pay. It's one of the staples of what we do and why we do it. And yet we cannot just stop there. It is not just as simplistic as we have four walls open and we have 2 doors open and we have telehealth services provided. And, if you want an appointment or you want to see us, then you have the ability to do that. We have to lean in further than that. When we look at demographics and we look at, our patient population, it's important for us to continue to think about where are those services most accessible and where do our patient populations want to be seen and how do they want to be seen. One of the most important functions that we have is continuing to listen and continue to partner with community. And the way in which we do that is we have to humble ourselves to do that. We oftentimes, due to all the education, the letters after our names, the white coat, the stethoscope, all these different things, oftentimes come to spaces as the subject matter experts, when ultimately the community is a subject matter expert on what community needs are if we're willing to listen. And so, that is one of the reasons why historically at Neighbor Care, we provide service. We are the largest school-based health center. We know that that is a very important outlet for providing services as a healthcare provider, to where students can receive services on site at school, which makes it more convenient and equitable for parents. And then in addition to that, to connect them to primary care services within our neighborhood clinics, and truly thinking of taking care of those kiddos from earlier years all the way on, and developing an opportunity for them to see preventative healthcare services as part of their everyday reality. So as they transition into adulthood, that is an area that they've already become accustomed to, regardless of what maybe some of those historical challenges and barriers have. They themselves, because they've had that access and that education, are able to better absorb that for how they transition into adulthood and beyond there. And then also, as we know, continuing to provide services for our homeless population is so important. Our unhoused population is so important. Needing to bring those services in locations where individuals most frequent, right? It's not just as simplistic as, oh, we have a clinic less than a mile away or 2 blocks away, because we know that folks are not comfortable walking into those spaces for all the different reasons why that's important. And then up to and including being able to provide behavioral health services for our populations, because we know that the physical health is tied to their mental health and vice versa. And that is an extremely important opportunity that we continue to carry on a regular basis. So truly continuing to lean into equity for all the reasons why that is important, to support our communities, support our families, support our kids, and support the next generation of Seattle in King County. I mean, not just be specific.
So let me ask you this. One of the greatest issues that public health has been faced with over the last 20 to 30 years, I would say, is this rapidly widening health disparity gap between different segments of our population across the United States. And as progressive and as forward-thinking as the Seattle, King County region or Washington State might be, unfortunately, we face the same sort of disparate health outcomes. You could pretty much take any issue, whether it's HIV, STDs, or diabetes, cardiovascular disease, obesity, mental health, substance use, fentanyl-related deaths, and you would end up with the same sort of picture emerging. Native Americans, African Americans, and then sort of, the distribution of disease burden. From your perspective and vantage point, how do you see that within the primary care arena, and what sort of deliberations are you guys having?
Yeah, I mean, everything you state, and it's a fantastic question. Everything that you state is a reality, right? And it's not, to your point, it's not something that just started overnight.
Right.
I mean, these are long-standing generational problems,
very
right?
much so.
And I would say, first and foremost, it's, how we better effectively use and leverage the data that we have at our disposal, right? So we know we have data that speaks specific to marginalized communities and populations, and what are some of the specific health disparities that they face, right? And we elect to utilize that data as we think about what are some of the programs, what are resources, what are funding opportunities to start to address some of these systemic issues. And yet, through time immemorial, we still have many of the same problems and the same issues. And so it's one of the reasons why it's going to be even more important that we think about partnerships differently than we have in the past. In many ways, we think about partnerships and even funding in terms of who historically has benefited from these types of partnerships. But when we think about the downstream impact of who ultimately we're aiming to impact, we largely miss the mark, right? And so that's going to mean that when we, even neighbor care and public health, are at the table and in utilizing these opportunities to come at these conversations and these necessary conversations in good faith around what are some of the ways in which that we continue to be barriers to what we're ultimately aiming to address, and how we can continue to look at the data, look at our communities, disaggregate that information, and specifically target programs and providing resources in a way that is more equitable and leans in from an equity perspective, but then also how we continue to give ourselves grace for what maybe has not worked, right? And be very specific and honest about that, and start to truly make some decisions and some action steps to truly start to move the needle in our communities.
Absolutely. I think you said it. Related to that, I think it would be a disservice to the discussion if we didn't mention the fact that sustainability of effort depends on resources. And you can say if you disagree. I know you don't.
Oh, I do not. Sustainability is extremely important. Yeah.
Right. And to that point, I think the way public health is financed, or government public health anyway, I'm not talking about academic public health, and the way community health centers are financed are very poorly understood by the two worlds. I had the unique privilege and honor of leading a federally qualified health center, which was an education for me, because you get to appreciate new perspectives and points of view that you otherwise would not have if I'd stayed on the other side. So, but you correct me if I'm wrong. 1/3 of your funding, roughly, comes from billable services. Another third, fund development, fundraising, and perhaps another third from HRSA grants, federal grants.
And in our case,
right,
public health
and public health, health grants and King County grants. But that, in general, is the bucket of funding, right? So there are 3 items within that bucket that are finite. The only sort of play around money to enhance services and introduce new lines of services is really fund development.
Yeah.
And I've been in your shoes. Fund development is a 24/7, 365 effort.
Yes.
This stuff costs money. And it is getting more and more expensive to provide the same unit of service to the same population, much less grow the program and introduce new slivers into that. On the public health side, we are also stymied by very siloed state and federal funding and local funding. I mean, it's no secret. You've seen the headlines in Seattle Times over the last year. We've had conversations with all our FQHC colleagues. The fact that we have to look towards sustainability of our system has been a major challenge in light of the fact that we really don't have, as a county, all the financial tools at our disposal that we would love. Inflation has begun to creep up. It has been creeping up. It's no secret. The cost of doing business is going up along with it, but revenue sources are flat. So, something's got to give in that adjustment. And I think item one on that list, whenever I have a conversation, it is to do exactly as you said earlier, which is manage expectations. We cannot be everything to everyone or do everything for everyone. And here's the reason why. This costs money that we don't have. Yes, we would love to add it to our aspirational list, but we need sustainability. We can't, go and hire people without guaranteeing them at least a year's worth of gainful employment. I mean, I'm being very conservative in saying a year. And nobody wants to stick around for that length of time. So it's impossible to think beyond the end of our noses and say, hey, I don't know what's going to happen 2 years from now or a year from now.
Yeah, that's been one of the biggest challenges, especially more recently, even, on the FQHC side, but then also just even in so many different sectors, when we even think about the continuing resolutions at the federal level, right? And we just continue to kick the can.
Right.
And, being able to strategically plan and prioritize with that level of uncertainty is extremely challenging, right? And to your point, being able to not only recruit, retain, but also develop a workforce under these conditions continues to be extremely challenging. And, sustainability, for all the reasons why that's important, we're continuing to have to deal with the day-to-day challenges, but we're also having to continue to be nimble enough to pivot to meet and match real community needs. I mean, the pandemic was something that we all didn't necessarily foresee, but we've had to jump in and be very intentional about how how we provide and meet the need for something that's so impactful across the spectrum of our world, and understanding that there are systemic health disparities that continued and were exacerbated even often by the pandemic. So it's extremely important for us to continue to think about and be intentional about sustainability and working across so many different sectors to ensure that we're advocating and utilizing our resources in the best way.
You said it. I mean, in the world of public health, if you were to ask us about our major concern right now, in addition to public health issues, it would be workforce retention and recruitment. The next generation of public health professionals and leaders who will rise to the top and lead state, federal, and local agencies 20, 25 years from now are simply not coming through. That pipeline has dried down to a trickle. According to some data from the de Beaumont Foundation recently, hardly 10% or 15%, I forget now, of MPH graduates from schools of public health, which is kind of the basic degree, are opting for government public health jobs. And that's because they've seen what happened to the public health workforce during the pandemic. They were burnt out, they were under the cosh, they were being victimized and had all kinds of stuff thrown at them, to the point that a lot of folks just quit and left for the private sector. And so that's where the pipeline diverted as well. And I suspect it's the same for PAs and MAs and nurses and, even physicians.
Oh yeah, no, we're seeing that as well. And seeing it in clinical roles, but also seeing it in administrative roles as well. I mean, we have shortages across the board. I mean, these are issues that transpired before the pandemic, and since the pandemic, it's gotten even worse, right? And we're still having to rebound mightily from that because, one of NeighborCare's aims is 100% access and zero health disparities, right? In order to even come close to achieving that, we're going to need to have the workforce in place to be able to not only recruit and retain, but able to grow and develop. To your point of the next generation of leaders in all of the important spaces on the public sector, those folks not coming through, that's going to impact our communities greatly. And it is incumbent upon us to make sure that we're able to provide those opportunities for folks from community and from outside community to be able to come in and work and to grow and develop their skill sets to be able to impact the lives of so many others. But our systems don't necessarily align with
Right.
that being the reality.
Right.
And so as we think about what that's going to mean, this is where some of those system-wide changes are going to be important. So we think about how primary care, specifically in our space, has been provided in this country. That's going to have to shift and change. We cannot continue to keep up with a volume-based structure for how we are funded
Right.
as a system in the
Yeah,
United States.
that formula is not going to
It
work.
is not going to work, no.
No, I completely agree. Let me pull your leg a little.
Yeah, sure.
So one of the interesting things, and I'm a transplant to the Seattle King County region.
We are kindred
but
spirits in that
actually
way.
we are, yes. So, you know, as a fairly recent arrival, it's always interesting to note things that are probably prone to some degree of improvement or need some degree of fine-tuning. One of those, in my observation, my extensive experience of nearly 2 years, has been the fact that we don't necessarily have a single platform around which community health centers in the region and public health actually come together. There are bits and pieces, and you know, it happens in piecemeal fashion. I meet with you, I meet with somebody else, you meet with somebody else, etc. But it's not happening around a unified agenda, precisely to your point, which negates the need for territoriality and competition. And yes, there is always a healthy amount of competition between community health centers. I mean, you know, they're not-for-profit corporate entities, so to speak. I know so because I've been in your shoes. Public health is the neutral convener in that mix. Once we, fingers crossed, knock on wood, get to the end of 2024 and have some degree of stability in our own clinical system, one of the agenda items I have on my calendar is to try and broker some sort of, you know, I even gave it a lofty title in my brain, so please don't fault me for being grandiose here. An integrated health network is what I called the idea when I was mulling it between me and myself. So it's not gone anywhere yet. But, you know, with friends and colleagues like you and Esther and everybody else that I've met, I think it is doable, but it will accomplish one singular aim: better coordination, avoiding hitting the same areas or people over and over again, so that we have clarity on roles and responsibilities, and frankly, joint endeavors wherever possible. Public health system is under a lot of pressure, even without this general fund crisis that erupted last year. To the funding piece that Rashad was talking about, I'll give you the perfect example. The National Association of Community Health Centers is an amazing agency. I have several friends that work there. I've learned so much from them. They work tirelessly to find all kinds of support for community health centers, as you well know. As they worked with Congress, one of the ideas that came up from the Senate was to find more money to support our community health centers. A legislator who I have a lot of respect for, who understands more than everybody else what this means, came upon the idea of using money from the Public Health Prevention Fund to take money from that and fund the need that arose within community health centers. Now, to me, that's like taking $20 from one pocket, putting it in your other pocket, and pretending you've got $40.
Or counting the $100, counting the money, flipping it over, and then
Exactly.
put cash again.
The idea is noble, but it is also extremely short-sighted, because what it does is hamstring public health in doing our prevention work, so that people don't need to seek emergency room care or routine primary care. They can remain healthy in their own homes and neighborhoods. It is to provide them the kind of education and support they need to keep up with their immunization schedules and hopefully find a doctor if they've got a history of diabetes or are pre-diabetic themselves before they encounter complications of the disease. So, your world and mine sometimes intersect, but also we have to then tease things apart and say, no, wait a minute, this is a terrible idea. You think it's a great idea, but it's a terrible idea.
Yeah, no, I agree. And I think that goes back to, a couple of things. I think as you talked about the integrated network, I think that forces us to, confront ourselves around, do we actually trust each other?
Yeah.
And defining that trust and what does that actually mean, right?
Yeah.
Because we know there's been starts and stops, there's been turnover, there's been transition, there's been all of these different things that have happened. So coming back to the table in good faith and defining what trust actually means and then being
Absolutely.
intentional about that. Then I would say to your point of some of how that can benefit the community as well and all of us and all of our efforts is, how are we aligning how we're utilizing this time and this resource in a way that's going to be most productive, right? So it's great to meet, but then again, are we meeting just to meet? Or are we meeting to intentionally get something done? And I also think that allows us to have different types of conversations at the table, right? Because historically, we've done a lot of the same things over and over and over again, expecting a different outcome, which is the definition of insanity. And so, but by talking about trust, talking about how we can, what are, being very clear and aligned around what are our outcomes and what our missions are and where we're aligned, it gives us a better opportunity to be able to move in a direction that is going to be more impactful for community, all the while growing and maintaining a workforce that we can sustain for the long haul of this work. Because to your point, there are going to be others in these chairs 25 years from now. And much of what we're deciding on today is going to what our I don't even want to use the word hope. What our intention is ensuring that they have the resources available to be able to take it to the next level, even far beyond what we're able to do.
Yeah, I could not agree more.
All right,
we have some questions coming.
We've got questions.
You want to do the honors, Rashad?
Ooh, yes, I can. Oh, so I'm going to read these out loud. So, as two leaders of color, how has your lived experience been important to your ability to move the needle on health equity?
Ooh, please.
Oh, I like it. I'm going to punt it to the reader. So, wow, we don't have enough time for me to dig fully into that one, but I will answer. So, a couple of ways. I think what is important in community always is that when we think about equity, it's more than just being on the receiving end. It's also being a part of decision-making and a part of, putting structures and systems together to benefit our communities. Right. And so I know personally, it has always been important for me to, as much as I possibly can, elevate not only just myself in spaces of importance in community, but also continue to elevate the conversation, because I know that there are so many in our communities who look for people who look exactly like them and who come from similarly situated communities, as well as have had a lot of the same shared and lived experiences to be part of ultimately what is being decided on that's going to impact them and their families and their communities. And so when I think about health equity, I think about so many different situations where I've seen people in my own family provided services or not provided services in an inequitable manner that ultimately did not yield the type of outcome that's important and should be affordable to everyone. So as we continue to remain in these spaces as leaders and as people of color, it's important that we appreciate these opportunities, but also are being very unapologetic about who we're ultimately aiming to impact.
Yeah. No, I completely agree. And I'm a migrant to the United States, proudly so. And so my own journey in the United States and building a life here over the last 25 years has taught me quite a bit about just how strange and idiosyncratic some of the constructs in American society can be. I had the privilege of living and working in other parts of the world before I moved to the United States. And in those parts of the world, I was always the doctor from Pakistan. As soon as you land on these shores, you're expected to check a box. You know, you're white, black, brown, Hispanic, non-Hispanic, Asian, sub-Saharan African, whatever. And it's a long list. And that was the first sort of point of education. And then I'm a student of social justice and a strong advocate for it. So I will speak very frankly about this. In the United States, I spent about 8 years before I realized that I had been receiving white privilege by default. And what I mean by that is people didn't automatically identify me as a minority or as a person of color, which was very interesting to me. Because that's how I viewed myself. And it was a case of sort of the model minority myth, but also, oh, doctor, oh, you know, Indian, Pakistani, educated, lawyer, doctor, engineer, IT, whatever that positive reinforcement cycle is. And when that realization occurred, it was a sobering moment. So I'm still learning, which is why I consider myself a student of social justice. Because unless we flip back the covers from those ugly truths that exist, nothing is going to change and nothing's going to improve. King County is a leader in those conversations. I'm very proud to tell you that Public Health Seattle and King County was talking about social justice and racial justice and health equity well before it was fashionable to ever do that, well before George Floyd. And so the declarations of racism as a public health crisis began to occur fairly regularly across the country post-George Floyd, if you'll remember. But that work had been going on for decades. And so I'm proud to work with people every day that have spent their entire lives trying to move the needle, as this individual asked. I don't think, honestly, I'm going to see the needle move in my lifetime because moving the needle takes a lot. It really is a monumental task. We are moving in the right direction, though. And I hope against hope that I'll see it before I finally sail off into the sunset. What would you do with 25% more budget? What's your focus in the near term?
He's the handoff guy. Oh, wow. 25% more budget. I think in thinking of 25% more budget, I immediately go to workforce. It's the first place I land to because ultimately we need to make sure that we're able to recruit, retain, and develop a workforce that is representative of our community, which is a important intention of ours as an organization, but also because when we talk about 100% access, that is heavily dependent on the workforce that we have and addressing our workforce needs. So that is that's what I think about with 25.
I cannot disagree with that. It is about more money for the people who do the work. I know Rashad enough to know that if I were to ask him to agree with me on this, he would. So I'll say it for both of us. Our job as leaders is to take care of the people who take care of the people. And that means paying them enough so that they can live comfortably and not have to worry about living paycheck to paycheck, not having to worry about being priced out of the housing market in the very neighborhoods that they're expected to provide services in. All of that requires money. And on the government side, certainly, we face a very rigid and antiquated civil service structure sometimes. It takes a lot to change the salary scale We've made a lot of progress. King County's been very progressive and very forward-thinking on that, but we really need to do much, much more, and that costs money. I'll give you one example. If you know, a manager or a supervisor in the tech sector makes 3 times as much as a manager in the public health sector, whose job it is to literally save the lives of individuals and entire families and prevent disease outbreaks every single day, that tells you something. I cannot fathom how that it is a good thing. Yes, it means more taxpayer money needs to be given to that sector to bring them up to par and to pay them what they truly deserve. And you know, it's just layer after layer of complication. But I completely agree with Rashad. 25%, it's going towards workforce retention and hopefully some more recruitment.
All right. So I want to say first and foremost, thanks to Dr. Khan for joining us today and for supporting Neighbor Care Health and supporting federally qualified health centers and community health centers. You know, the work that we do is extremely important, and we continue to appreciate strong strategic partnerships such as what Neighbor Care and public health have had for decades. And we know that there's more hard work ahead of all of us, and that it's only going to be even more important for not only us to continue these conversations, but to continue engagement in all the important ways that's necessary, but then also continuing to involve what that looks like, because that's what our communities deserve. And it is our responsibility to carry that forward.
Absolutely.